in the bills that you've supported that puts control in Washington, that we have a very difficult time supporting those provisions. And it's not a matter of just saying we all agree on the goal of reducing waste, fraud, and abuse. We all do, of course. It's how you do it. Now, let me give you a couple of examples. Dave Camp, I think, pointed out the answer to the dispute that you and Lamar Alexander had a moment ago, and he was exactly right. Let me quote from the Congressional Budget Office letter. This is from Doug Elmendorf to Evan Bayh, November 30th, 2009. Quote, CBO and Joint Tax Committee estimate that the average premium per person covered, including dependents, for new non-group policies would be about 10% to 13% higher in 2016 than the average premium for non-group coverage in the same year under current law. Oliver Wyman, a very respected third-party group, says it's even more, about 54%. In my state of Arizona, 72% increase. Why is it so? For a variety of reasons, but one of which both you and Dave Camp agreed on. It is a richer benefit. How did it get that way? Because the federal government would mandate it under your legislation in the insurance exchanges. And as a result, there would be a higher cost. How does this happen? There is an actuarial requirement of 60% actuarial value in the exchange for the least costly plan. But the average in the country today of a high deductible plan is 48%. The range today is 40 to 80%, and the average is between 55 and 60. So what the government is doing here is saying, we're going to mandate that the insurance cover more things than it does right now, and therefore the cost is going to go up. Second example, you say, how can we help small businesses? Well, we know one way you don't help small businesses is by raising the payroll, the Medicare payroll tax on them, which is what this legislation does. Besides that, it's a job killer. Look at the taxes on beneficiaries as well. This is a third example. You don't cut costs when you raise taxes on medical devices that help us, when you raise taxes on pharmaceutical products, when you raise taxes on the insurance premiums themselves. Quote, these fees on insurers, medical devices, and pharmaceuticals would increase costs for the affected firms, which would be passed on to purchasers and would ultimately raise insurance premiums by a corresponding amount. Congressional Budget Office. So when you raise these taxes and all of the different fees that are in this legislation, it inevitably increases the costs on the consumer. And why do you have to raise all of this money? Because of the expenses of the legislation that underlie all of this. That's why Republicans would rather start not by having to raise a lot of money in order to pay the high cost of this bill, but to start a piece at a time directing solutions to specific problems. That way you don't incur all of the costs up front, which require you to raise the taxes. Last quick point. One of the worst things about this is for people that have catastrophic medical expenses today, after you've spent 7.5% of your adjusted gross income, you can deduct that. This bill would raise that to 10%. Who does that hurt? The very people you promised, Mr. President, that you wouldn't allow taxes to be raised on. Average age, 45. Average income, $69,000. These are not wealthy people. Just another example of why, because the bill has to raise so much money, it ends up hurting the very people that we want to help.
Okay, John, I'm going to go to you, Jim, but since, as has tended to happen here, we end up talking about criticisms of the existing bill as opposed to where we might find agreement. I feel obliged just to go through a couple of the points that you raised. Just to go back to the original argument that Lamar and I had, and we've now chased around for quite some time. Look, if I'm a self-employed person who right now can't get coverage or can only buy the equivalent of Acme insurance that I had for my car. So I have some sort of high deductible plan. It's basically not health insurance, it's house insurance. I'm buying that to protect me from some catastrophic situation. Otherwise, I'm just paying out of pocket. I don't go to the doctor, I don't get preventive care. There are a whole bunch of things I just do without. But if I get hit by a truck, maybe I don't go bankrupt. All right, so that's what I'm purchasing right now. What the Congressional Budget Office is saying is that if I now have the opportunity to actually buy a decent package inside the exchange that costs me about 10 to 13% more, but is actually real insurance, then there are going to be a bunch of people who take advantage of that. So yes, I'm paying 10 to 13% more because instead of buying an apple, I'm getting an orange. They're two different things. Now, you can still, you still have an option. No, let me finish. The way that this bill is structured uses a high cost pool, a catastrophic pool, for people who can't afford to buy that better insurance. But overall, for a basic package, which by the way is a lot less generous than we give ourselves in Congress. So, I'm amused when people say, let people have this not so good plan, let them have a high deductible, but there'd be a riot in Congress if we suddenly said, let's have Congress have a high deductible plan, because we all think it's pretty important to provide coverage for our families, and the federal health insurance program has a minimum benefit that all of us take advantage of. And I haven't seen any Republicans or Democrats in Congress suddenly say, you know what, we should have more choices and not have to have this minimum benefit. So what we're basically saying is we're going to do the same thing for these other folks that we do for ourselves. On the taxpayer's dime, by the way. Now, there is a legitimate philosophical difference around that, but I think it's just very important for us to remember that saying there's a baseline of coverage that people should be able to get if they're participating in this big pool is not some radical idea. And it's an idea that a lot of states, we were talking earlier about what states do. A lot of states already do it. This, by the way, goes to the other difference that we have when it comes to interstate purchase of insurance. Actually, this is a Republican idea, been championed by the Republicans. We actually agree with the idea that maybe if you get more regional markets and national markets as opposed to just state-by-state markets, you might get more choice and competition. People would be able to say, gosh, there's a great insurance company in Nevada, and I live in New York, and maybe I can purchase it. That's actually something that we find attractive. So do you guys. But again, the one difference, as I understand it, and the reason you're not supporting the approach that we take, is what we say is there should be sort of a minimum baseline benefit, because if not, what ends up happening is you can have a company set up in Nevada. Let's assume there were no rules there. There are no protections for the woman who's got breast cancer. They go into New York. They offer pretty cheap insurance to everybody who's healthy. They don't offer the same insurance to people who aren't so healthy or have pre-existing conditions. They drain from New York all the healthy people who are getting cheaper rates, but now suddenly everybody left in New York who doesn't qualify for that cheaper plan is in a pool that's sicker, older, and their premiums go up. So what we've said is, well, if we can set a baseline, then you can have interstate competition, but it's not a race to the bottom. Rather, everybody's got some basic care. Now, these are legitimate arguments to have, but I just want to point out that this issue of government regulation, and which we're going to also be talking about with respect to insurance, is very different than the way this has been framed during the course of the debate over the last year, which is government takeover of insurance. This is not a government takeover of insurance. What it is saying let's set up some baselines and then use market principles, the private sector, and pooling in order to make sure that people get a better deal. So, Jim, and then what we're going to do is we're just going to move on to the next topic, but anybody who wants to pick up on what we've just talked about obviously can return to that as well.
Thank you very much, Mr. President. Mr. President, leaders and members of the Congress. Look, there are two cost containment issues that I think have not been sufficiently vetted here today. Let me set this up by sharing with you a conversation I had on yesterday with the administrators of the Dillon or McLeod Healthcare Center in Dillon, South Carolina, a little town, Mr. President, you've become quite familiar with. They told me that their emergency room activities have doubled over the past several years. And they were looking for some assistance to expand the size of that emergency room. When I began to question them as to why in this small county, not in my district, they had such a doubling, what it turns out is that they told me that 31% of the people that they treat in that emergency room are not there for emergencies. They are there for primary care. Now, they said to me that some of these people do not have health insurance, but many of them do have health insurance, but they cannot afford the $1,500 to $2,000 deductibles that they would have to pay if they were to go to a private primary care provider. So they're now treating people who've got employer-based health care that they cannot use. They're holding that for some catastrophic event, but they need some assistance. Now, I think that no matter what kind of plan we develop, there will be many people left uncovered, and we need a safety net for those people. I believe that the one way to provide that safety net and to take care of all of those people who may be uncovered and those people who have $2,000 deductibles with primary care is for a significant expansion of community health centers. And we have not spoken about that here today, but I know that your proposals, Mr. President, I know that both the House and Senate plans have that in them, and I do believe that that is very, very important. We have more than a 40-year experience with these healthcare centers, and I do believe that no matter what we do, there ought to be a significant expansion of those healthcare centers. Secondly, Mr. President, a lot of other things have been said about what I have on this paper, but one other thing I would like to mention, and it has to do with people who really cannot navigate the system. People who work very hard, they know what they need for themselves, but I was reminded of that when we talked about putting together restaurant owners who will design plans for their members. I would hope that when we started designing plans for the members of small businesses, let's keep in mind that the employees of those small businesses are not negotiating these plans. They are at the mercy of the small business owners, and the question is whether or not the plans are sufficient that they will not fall into the same category that these people with $1,500 to $2,000 deductibles. Finally, Mr. President, this morning I was doing one of these call-in shows on C-SPAN. A gentleman called in, and he was very, very emotional. He said to me that he was getting ready to have transplant surgery, but he was told by the hospital that because he's on Medicare, that his post-operative treatment is going to be limited to 3 years. After that, he'll have to find some way to pay. This man was very emotional today. What we're doing here fixes that, and I do believe that we ought to really be honest with the American people. When we talk about what we are doing with Medicare, we are trying to make sure that Medicare is there for that man and so many others who will find themselves in his position. With that, I'll yield back, Mr. President.
Okay, I think this has actually been a very useful conversation. What I'm going to do is move on to the next topic, but maybe after we break for lunch and come back, I want to go through some areas where we decided we agreed. I know the abuse is a good example. Some areas where we still disagree. One thing, John, you shook your head when I said that people would be able to choose the better plan because the notion was, well, people are mandated. Actually, any insurance that you currently have would be grandfathered in so you could keep. And so you could decide not to get in the exchange the better plan. I could keep my Acme insurance, just a high deductible catastrophic plan. I would not be required to get the better one. If I chose to get the better one, it would be 14 to 20% cheaper than if I were going into the individual market. I just want to clarify that issue.
Well, Mr. President, if I could clarify, that's for a very limited period of time, number one. Secondly, the incentives are set up so that employers would drop you from their coverage because it's cheaper for them to pay the fine than to continue to pay the insurance, so they wouldn't be able to keep what they have. And third, there are still mandates in the legislation as to what you can do with what you have such that it doesn't end up being the same coverage. So with all due respect, I disagree. And it's just a fundamental disagreement between us. Does Washington know best about the coverage people should have, or should people have that choice themselves? Pay a little less, get a little less coverage, or pay a little more and get more coverage?
Can I just say that at this point, anytime the question is phrased as, does Washington know better, I think we're kind of tipping the scales a little bit there, since we all know that everybody is angry at Washington right now. I think so it's a good way of framing. It's a good talking point, but it doesn't actually answer the underlying question, which is, do we want to make sure that people have a baseline of protection? And this topic of the insurance market reforms, I think, is a good additional example of what may be philosophical differences, but what we may have in common. Rather than go through the problem, because I think everybody understands out there the issue of people with pre-existing conditions not being able to get insurance, people coming up with, bumping up against lifetime caps and suddenly thinking, as a family I met in Colorado, they thought their child was covered. Suddenly they hit the lifetime cap and they started having to scramble to figure out how they paid the additional costs. We all are familiar with these examples. I just want to go through areas where I think we agree on insurance reforms, or at least some Republicans and some Democrats agree. I think that we agree on the notion that you can't just drop somebody if they've already purchased coverage. Looking at your bill, John, the idea that you ban rescissions. We agree on the idea of extending dependent coverage to a certain age. Some people say up to 25, some people say up to 26, but we basically agree on that concept. We agree on no annual or lifetime limits. We agree philosophically that we want to end the prohibition on pre-existing conditions. I think the thing we're going to have to talk about is, how do you actually accomplish that? There may be a disagreement as to whether you can do that without making sure that everybody's covered. But that's something that we can talk about. In addition, though, there are some other insurance reforms that have been proposed by the House and Senate in their legislation that I think we should explore. And maybe we can narrow the gaps there and come up with some, even a longer list of areas that we agree on. So what I do is, since I want to make sure that Mitch doesn't give me a time clock tally again, let me first go to Mitch, and I don't know who wants to make the presentation with respect to insurance reform.
Mr. President, I'd like to yield to Dr. Bastani to continue this conversation about insurance reform.
Thank you, Leader Boehner, and thank you, Mr. President. I come at this as a physician, a cardiovascular surgeon with over 20 years of practice doing open heart surgery, dealing with patients who have come to me with very, very challenging cases at very difficult times in their lives. And along with my colleagues, Dr. Coburn and Dr. Barrasso, we bring a wealth of experience in dealing with insurance companies and all these everyday problems that so many American families face. We all agree. We all agree that we need insurance reform. There's no question about it. The question is, how do we do it? Now, we've all been through a long year. Town hall meetings, telephone calls, emails, it goes on and on. And one thing that has become very clear, the American people have spoken out very loudly and very clearly. They want us to take a step back and go step by step with a common sense plan that really brings the cost down for American families and small business owners. They want insurance companies to treat them just like they treat big labor unions and large companies. It's been a resounding message we've heard over and over. So how can we achieve all this? Well, we've talked about some of it. I think one of the things we ought to really look at is how do you simplify, streamline, and standardize all the paperwork that's involved? Because I can tell you as a doctor, and my two colleagues who are physicians will know, that it takes you away from patient care. It interferes with the doctor-patient relationship. It runs up cost in medical practices, and it's a real issue. So I think we can all agree on that. We need to address that issue. A second area is how do you really promote choice and competition? We've all talked about it, and I think we've had a lot of discussion already on those issues. We put forth a plan earlier in the year during debate that actually the Congressional Budget Office showed that it brings down the cost of premiums up to about 10%. And actually for individuals seeking and families seeking insurance in the individual market, those cost savings could even be higher. As opposed to the bill we have here, where we've had some discussion already, and Mr. Camp has already outlined, as well as Mr. Kyle, that this bill would actually raise premium costs. We've talked about small business health plans. You know, again, I ran a small business. It was a medical practice. And when I wanted insurance, when those premiums were going up in double digits every year, I'd call an insurance agent. They would come in. And we had very limited choice. Very limited. And the cost kept going up. Small business health plans is one way to really deal with this and allow for pooling. And where our big disagreement is, frankly, it's with how you do it. And if you create a plan with exchanges that are overly restrictive, it really doesn't, it defeats the purpose. And I believe we can have faith in the American public to figure out, if it's transparent enough, what's their best deal? What's the best deal for a small business owner or a family in this sort of arrangement? The same goes for purchasing insurance across state lines. I'm glad to hear our Democratic colleagues agree that this is an approach that needs to be taken to promote choice and competition. But again, we feel that this bill restricts those options too much. And we think we can do it in a responsible way. I believe we probably could come together on this. But I think the existing proposals restrict it far too much. Health savings accounts. These are very, very popular among small business owners and families. And I think the one impediment today is the inability to save enough in these. And I think there are ways that we could promote these health savings accounts and promote real savings that will actually make a difference. It won't solve all the problems, but it's an important insurance reform that I think small businesses will really, really jump on if we could expand those savings opportunities. The current bill, as has been stated, adds some restrictions and some additional tax provisions on these, which make them less palatable. We all agree on prohibiting insurance companies from arbitrarily canceling insurance policies. That's a no-brainer. There's strong agreement on both sides of the aisle there. Now, with regard to pre-existing conditions, this is an issue that is very difficult, and many of us and our families may have been faced with it. I can tell you I faced it when I closed my medical practice because I had a health condition, an arthritis condition. And I went to the same insurance carrier that covered my small medical practice for 14 years and got the big red no. Can't insure you or your family. Now that's frankly unacceptable. Now, what we propose is using risk pools, expanding these risk pools, and reinsurance. It's an affordable way to do it. It creates certainty for a family that's faced with this very difficult set of circumstances. Certainty is important, and our plan would not raise premium costs extravagantly, whereas the proposal here would raise those costs, and it doesn't really create the kind of certainty a family needs, because there are waiting lists, and that proposal is only temporary to something else that we don't know what it's going to be. The other thing we do is we create a way for small business owners to actually shop and compare apples to apples. Transparency. And this is critical. Our plan does this without creating the kinds of restrictions that we see with the exchange process. And we agree that we have to eliminate annual and lifetime caps, so we have broad agreement there. So again, I think it's clear that the American people have rejected the bills that have gone through so far because they see increases in premiums for families. They see that it raises taxes significantly on families and raises Medicare to create a new entitlement. This doesn't really bring down the cost. This is really not the answer. What American families want is a common sense, step-by-step approach that will really lower the cost for families and small businesses.
All right.
I believe we have a duty to reform health care, but we have an obligation to get it right.
Okay. Thanks, Charles. We're going to go to George Miller, and if you want to respond to specific things that Charles raised or make some more general points, we'll then go back to a Republican. At some point in this discussion, and we're going to have to be a little more disciplined in our time in order to stay on schedule on this section. At some point, I'd like Secretary Sebelius, who is not only a former governor but also insurance commissioner, to address some of the issues that have been coming up around insurance and minimum payments.
Mr. President, I don't know if any of us were told what the time limits are.
Well, I'm trying to be flexible.
I'm just curious if we've got a certain amount of time.
We've got about half an hour remaining for this section, so if people can keep their
Thank you.
Mr. President,
points brief.
From the Senate, we have Senator Harkin and Rockefeller respond
Right,
to the Democrats.
and I've got a list. George?
Thank you very much. This issue of insurance reform is, I think, where most families intersect with their insurance companies, with the health security of their families. And let's start out with our commonalities in the bill that Congressman Boehner, Leader Boehner, offered on the floor. He agreed that lifetime caps should be abolished, that annual caps should be abolished, that young people should be able to stay on their parents' plan. I think it was 25. I think in your suggestion, Mr. President, it's 26. So there's that kind of commonality there. But we think that, and our bill goes further in some of the suggestions you've made in the interim since the House and Senate have passed these bills, is that clearly we think that preventative care should not carry a copay with it, that we ought to encourage people to get that kind of preventative care for themselves, certainly for their children. We allow the health savings accounts to continue. That's a variation on, as my colleague talked about, what they think insurance reform should reflect. Clearly now, when we see the request in California for a 38% increase, in Michigan for 56% increase, I think in Maine is 27% increase. You've suggested stronger language than we have in either the House or Senate bill, I think along the lines what Senator Feinstein has been talking about in terms of rate review. People are trapped in these systems. But the one area where there still seems to be disagreement, it was not in the substitute offered by the Republicans when we were on the floor, and that is this question of pre-existing conditions, because this is a real trap for families. Either because you find out that you need to go to get care for a disease or an illness, and you may get a checkup and they may discover that you have arthritis, but you didn't disclose you had arthritis, so now that's a pre-existing condition and you may lose that policy. You may have to provide more. And the fact of the matter is, you hate to admit this at my age, but I sit here with two artificial hips, a little bit of arthritis, and I have a kidney stone. I'm dead in that insurance market if I have to switch policies or switch companies or look for another chance. Now, why should that be? Those hip replacements have been with me for 15 years, and I have no trouble. But it's a way of denying me care. And if you have acne, it's a way of denying you care. In fact, as you see from one of the Blue Cross companies here, there's 3 pages of things that will keep you out of care, will keep you from changing your jobs. And it goes on and on and on. With those, back pain will keep you, a pre-existing condition. Acne that I mentioned, a cleft palate that we talked about earlier here, it means that. So what does that mean when you want to change jobs? What does that mean when you want to start your own company? It means you go without insurance. Or you pay some policy that has a $5,000 deductible or $7,000 deductible. This is a real issue to American families. 56 million people right now have insurance policies where pre-existing conditions can knock them out at any given time. We know that 13 million people were denied coverage over the last 3 years because of pre-existing conditions. And so now you're trapped. You have a pre-existing condition. You can continue maybe with that insurance company if you pay more, but you can't shop in the marketplace for another insurance company. You can't go from Blue Shield to Kaiser because you have a pre-existing condition. You start to see the economic trap and uncertainty that families are confronted with. Now, the interesting thing was, during these negotiations, Senator Dodd and I worked very hard on these issues. Most of the business community signed off on getting rid of these pre-existing conditions, and I think that that's important for us to understand that is what real insurance reform is about. Should you still be able to charge women more than men? Should you rate based upon gender? To what extent can you rate based upon ages? What's the essential benefit that we're providing? We can all describe that plan that's really inexpensive. It just doesn't have many benefits that go with it for families. And so I think that this is a very important part of this discussion. I know when I go home in my district, I hear about this from the people I represent. I hear about this from my wife, and she's talking about our kids and her friends and people she spends time with, how they struggle with these. And what we're really talking about is the manipulation to move people around within the insurance market. And yes, you can go to a high-risk pool. So yes, because you have a pre-existing condition, because I have 2 artificial hips, I can go to the most expensive insurance system in the country. I'm now in a high-risk pool, and I'm trapped in that high-risk pool forever. You can make it a high-risk pool among states. You can make it a high-risk pool among small businesses. You can make it a high-risk pool among large businesses. I'm still trapped in the most expensive insurance because of something that happened to me that I had no control over. I have a child with a cleft palate. I have a child with acne. How can this possibly be? Now, fortunately, in our discussions, as I said, a lot of the business organizations have agreed that these things should be phased out over time. Some can be put in right away, as it's not terribly expensive to cover people 18 to 26, and that can be done right away, and we have that commonality. So I would just hope that we would focus on this issue of what real insurance reform looks like with respect to the impacts on families and individuals as they try to navigate this insurance market.
Thank you, George.
Mr. President, we'll turn now to John McCain.
Well, thank you, Mr. President. Thank you for doing this. And I understand the 4 categories, but there's a big category that the people in my state and across this country are deeply concerned about. And that's not just the product that we are examining today, the 2,400 pages, but the process we've gone through to reach that. Now, both of us during the campaign promised change in Washington. In fact, 8 times you said that negotiations on health care reform would be conducted with the C-SPAN cameras. I'm glad more than a year later that they are here. Unfortunately, this product was not produced in that fashion. It was produced behind closed doors. It was produced with unsavory, I say that with respect, deal making. The Louisiana Purchase, funding of $300 million for one state. The Cornhusker kickback, which is, I understand now, been done away with. One of the things that, as provisions of this legislation that was particularly offensive was the carve-out for 800,000 Florida seniors exempt from cuts in Medicare Advantage program. There's 330,000 seniors under Medicare Advantage in my home state of Arizona. They're deeply concerned about that. They're deeply concerned about the carve-outs for Vermont, Massachusetts, Hawaii, Michigan, Connecticut. $100 million for a hospital in Connecticut. Why should that happen? They don't understand it. And at the town hall meetings that I conduct all over my state, people are angry. We promised them change in Washington, and what we got was a process that you and I both said we would change in Washington. So then we got into the special interests, whether it be the Hospital Association or the AMA or others, and one of them that was particularly egregious, and I won't go through the whole list, was pharma. Pharma got an $80 billion deal, and in return for which they ran $150 million worth of ads in favor of, quote, health reform. Their over $2 million a year lobbyist was here at the White House and was reported to say in the media, a deal is a deal. And part of that deal was that there would not be competition amongst pharmaceutical companies for Medicare patients. The other, well, among others, was that the administration would oppose drug reimportation from Canada, a proposal that you supported in the United States Senate.
John,
And
can
Christmas,
can I just say...
can I just finish, please?
Well-
And then at Christmas Day, I believe it was Christmas, the majority leader said, quote, a number of states are treated differently than other states. That's what legislation is all about. That's compromise. Compromise is not the word for that. So when my constituents and Americans now who overwhelmingly reject this proposal say go back to the beginning, they want us to go back to the beginning. They want us not to do this kind of legislating. They want us to sit down together and do what's best for all Americans, not just for some people that live in Florida or happen to live in other favored states. They want a uniform treatment of all Americans. So I hope that that would be an argument for us to go through this 2,400-page document, remove all the special deals for the special interests and favored few, and treat all Americans the same under provisions of the law so that they will know that geography does not dictate what kind of health care they would receive. I thank you, Mr. President.
Let me just make this point, John, because we're not campaigning anymore. The election's over.
I'm reminded of that every day.
Yeah. So we can spend the remainder of the time with our respective talking points going back and forth. We were supposed to be talking about insurance. Obviously, I'm sure that Harry Reid and Chris Dodd and others who went through an exhaustive process through both the House and the Senate with the most hearings, the most debates on the floor, the longest markup in 22 years on each and every one of these bills would have a response for you. My concern is that if we do that, then we're essentially back on Fox News or MSNBC on the split screen just arguing back and forth. So my hope would be that we can just focus on the issues of how we actually get a bill done. And this would probably be a good time to turn it over to Secretary Sebelius.
Could I just say, Mr. President, the American people care about what we did and how we did it.
Well,
and I think we ought, and it's a subject that I think we should discuss, and I thank you.
They absolutely do care about it, John, and I think that the way you characterized it obviously would get some strong objections from the other side. We can have a debate about process, or we can have a debate about how we're actually going to help the American people at this point. And I think that's, the latter debate's the one that they care about a little bit more. So, Kathleen, why don't you just address some of the issues related to insurance reform? There's some agreement here, but I know that on the Republican side, there are a couple of concerns about the issue of rate review, the issue of setting up some benchmark standards that insurance companies have to abide by. Some people may think that those have been a little bit too aggressive. You've been both a governor as well as an insurance commissioner. Maybe you can talk a little bit about what you've seen at all those different levels and how you think we can best move forward to protect American families.
Well, thank you, Mr. President, and I know there are lots of people who want to comment on these topics, but I don't think there's any question, and I think there's a lot of agreement that the current insurance market really fails way too many people. It is a system that is not a market for about 40 million Americans who are either in an individual policy or in a small group policy, have no choice. There is no competition. According to the American Medical Association, in their study yesterday, 99% of the market in metropolitan areas, 75% of the markets across the country are very concentrated, which means they're monopolies. They're not markets. So we got a trap. And I think the rules allow people to be locked out from the front end if you've got pre-existing conditions, allow people to be thrown out with a stop on benefits during the course of a treatment, or when your policy expires and you're supposed to renew, you're dumped out of the market, or to be priced out, which is going on across this country. There's been a highlight of a couple of rates, but double-digit rates across the country, on top of double-digit rates, on top of double-digit rates, and people have no choices. So the common areas, I think, of agreement, high-risk pools. There are lots of states across the country running high-risk pools. As an insurance commissioner, we ran the high-risk pool in Kansas. It is a strategy that's been in place for almost 30 years in many states. 200,000 people total in the entire United States are in high-risk pools because they're so expensive that they really don't offer it. Because when you put all the sick people together and you say, okay, you get to buy a policy, and you get no help with that policy, it is a death spiral. You will always have the highest cost, and on top of that, the highest cost, and you've got the sickest people who are already paying the highest cost for treatment. They don't work very well. They are a stopgap measure that the House and Senate have proposed to get people from here to a new market. I think what the exchanges have a lot in similarity with the health plans that have been talked about by the House and Senate. There's a big difference, and it's not a Washington difference, it's a state difference. The state insurance commissioners across this country have unanimously opposed health plans for decades, and they feel that it takes people, it isn't the pooling that's objectionable, it's the fact that there is no consumer protection, that there is no ability to apply common sense rules. And we had the drive-by deliveries in Kansas where people were being kicked out of the hospital 18 hours after having a baby to save money, only to be readmitted with jaundice and to be readmitted with dehydration. It's not a particularly good idea. So getting rid of pre-existing conditions, getting rid of caps on yearly benefits and long-time benefits, allowing kids to stay on plans are ideas that have been accepted by both, setting up a new marketplace, giving small business owners and individuals choice and competition in the private sector, but making the private sector operate on a different set of rules, including having some loss benefit analysis. How many of those dollars, you heard Senator Coburn eloquently talk about the 30 cents of every dollar that goes to pay for expenses other than medical costs. A loss benefit analysis, a medical ratio would do just that. How many of your dollars are you actually spending on provider care, on prescriptions, on treatments, and how much is going to overhead and CEO salaries and advertising? to try and get a handle on rates, having some rate review, having some transparency and some opportunity to have people make choices and make companies compete with one another and not separate the marketplace. I think the most dangerous part of the system right now is having people, having insurance companies pick and choose who gets coverage and who doesn't based on your health condition. It's a lot cheaper to insure people who promise never to get sick. I watched it as insurance commissioner, but segregating that market is not insurance. It's not pooling a risk. And I think your proposal, Mr. President, gets back to the notion that there'd be a pool. There'd be an opportunity to pool that risk and have people have the kind of negotiating power as a governor. And like Senator Alexander, I am a former governor. We both ran our state employee health pools. I don't know about Tennessee, but in Kansas, that was the largest pool in the state, 90,000 covered lives. We had a lot of negotiating power. We could get a pretty good deal on a couple of companies competing on hospital rates, on doctor rates. That's what this kind of pooling mechanism and a new exchange would give everybody. And it's around a set of standards that made sense.
Okay.
Mr. President.
Yeah.
Mr. Cantor, please.
Eric?
Mr. President, thank you again very much for having us and for staying with us for the 6 hours. Appreciate that. I don't know if you will after the 6 hours or not, but
I gather, let me just guess. That's the 2,400-page health care bill. Is that right?
Well, actually, Mr. President, this is the Senate bill along with the 11-page proposal that you put up online that really I think is the basis for the discussion here. So, but I do want to go back to your suggestion as to why we're here. And you suggested that maybe we are here to find some points of agreement to bridge the gap in our differences. And I do like to go back to basics. We're here because we Republicans care about health care just as the Democrats in this room. And when the Speaker cites her letters from the folks in Michigan and the leader talks about the letters he's received, Mr. Andrews his, all of us share the concerns when people are allegedly wronged in our health care system. I mean, I think that is sort of a given. We don't care for this bill. I think you know that. The American people don't care for the bill. I think that we've demonstrated, in the polling that they don't. But there is a reason why we all voted no. And it does have to do with the philosophical difference that you point out. It does have to do with our fear that if you say that Washington can be the one to define essential health benefits, there may be a problem with that. And that's the language in the Section 1302 of this bill, that it says that the Secretary shall define for people what essential health benefits are. But let's, in the spirit of trying to come together, let's try and say maybe if we assume that Washington could do that, could really take the place of every American and decide what is most essential, what would be the consequences? And that's also where we have a big difference in this bill and what would happen. First of all, the cost. And John Kyle laid out the tremendous costs and the nearly $1 trillion of this bill, and I don't quite know because CBO said it couldn't assess how much your additions would cost to it, but we do know that there are plenty of taxes on income now. You suggest investment income should be taxed. We have additional taxes on medical devices and the rest. What is the consequence of that? We know there are consequences that small businesses will feel because of the impact on job creation. But also, Mr. President, when we were here about a year ago across the street, you started the Healthcare Summit by saying one of the promises you want to make is that people ought to be able to keep the health insurance that they have. Because as we also know, most people in this country do have insurance, and overwhelming majority of people do like that coverage. It's just too expensive. Well, the CBO sent a letter, I think it was to Leader Reid, about the Senate bill. And in that letter, it suggested that between 8 million and 9 million people may very well lose the coverage that they have because of this, because of the construct of this bill. That's our concern. And so as we are in the market, in the section of this discussion about health insurance reform, I know, Mr. President, that you have suggested strengthening oversight of insurance premium increases because we want to make sure that there aren't excessive insurance premium increases that take place. The problem is when you start to mandate all of the essential benefits, there are going to be some insurance premium increases. None of us really want to see them, but if you stop them, who's going to pay for it? Well, when we get back to the fact that businesses won't be able to pay for it and people are going to lose their coverage. So I guess my question to you is, in the construct of this bill, if we want to find agreement, we really do need to set this aside. And we really do need to say, okay, you know, the fundamental structure is something we can agree on, but there are certainly plenty of areas of agreement. And because I don't think that you can answer the question in the positive to say that people will be able to maintain their coverage, people will be able to see the doctors they want in the kind of bill that you're proposing.
Well, let me, since you asked me a question, let me respond. The 8 to 9 million people that you refer to that might have to change their coverage, keep in mind out of the 300 million Americans that we're talking about, would be folks who the CBO, the Congressional Budget Office, estimates would find the deal in the exchange better, would be a better deal. So yes, they would change coverage because they've got more choice and competition. So let's just be clear about that, point number one. Point number two, you know, when we do props like this, you stack it up and you repeat 2,400 pages, et cetera, you know, the truth of the matter is that healthcare is very complicated. And we can try to pretend that it's not, but it is. Every single item that we've talked about on the Republican side, if we wanted to exhaustively deal with fraud and abuse, would generate a bunch of pages. So I point that out just because, you know, these are the kind of political things we do that prevent us from actually having a conversation. Now, let me respond to your question. We could set up a system where food was probably cheaper than it is right now if we just eliminated meat inspectors. And we eliminated any regulations in terms of how food's distributed and how it's stored. I'll bet in terms of drug prices, we would definitely reduce prescription drug prices if we didn't have a drug administration that makes sure that we test the drugs so that they don't kill us. But we don't do that. We make some decisions to protect consumers in every aspect of our lives. And we have bipartisan support for doing it. Because what we don't want is a situation in which suddenly people think they're getting one thing and they're getting something else. They're harmed by a product. What Secretary Sebelius just referred to, which is not a Washington thing. In fact, state insurance standards in many states are higher than anything that's done in Washington, is as a consequence of seeing consistent abuses by the insurance companies and people finding themselves helpless to deal with them. Now, we can have a philosophical disagreement about how much insurance regulation is appropriate. What you've indicated to me, just based on the bills that I've seen, is you guys believe in some regulations. You already said you did. You believe in making sure that you can't just drop somebody with coverage. Now, if you don't have a law there, let me tell you, that happens all the time. I've got a bunch of stories in here of folks who thought they had insurance, got sick, the insurance company goes back and figures out a way to drop them. I'm not making this up. I'm not trying to just add to the pages of that bill. It's in response to an actual problem, and you guys have agreed to it. So, philosophically at least, on a whole range of issues, you agree that we should have some insurance regulation. My suggestion had been that we try to focus on what are the specific regulations, since We agree that there have to be some. What are the specific ones that you object to? Now, let me just close by saying this. Pre-existing conditions is one that theoretically we all say we agree on. Theoretically, everybody thinks it's a bad deal if my wife's had breast cancer, I lose my job, I now try to buy insurance, and they say, well, you know what, we can't cover you because your wife has a history of cancer. We all think that's a bad deal. There are two ways of dealing with that. One is what Kathleen raised, which is a high-risk pool. You could say, you know what, you can go in there and buy it in a big high-risk pool. And by the way, you could probably set up a high-risk pool without having as many pages in the bill. And it's an option that's been around for 30 years. Here's the problem. What happens is the reason that all our rates as members of Congress or as elected officials are pretty low is we've got such a big pool. There are millions of federal workers. And as a consequence, any single one of us have cancer, any single one of us have a child with a disability, our costs are spread out over millions of people, and so all of us are able to keep our rates relatively low. Even though if any individual in that situation was trying to buy insurance, it would skyrocket. That's the concept of pooling, is you get the healthy people and the young people alongside the not so healthy and the older people. But we're all kind of spreading our risk because each of us don't know at any given time what might happen. Maybe our kid's the one who gets diagnosed, heaven forbid, for something. And as a consequence, we insure ourselves by making sure that we're also insuring somebody else. When you get into something like a high-risk pool, what happens is all the sicker, older people are in that pool. All the younger people, they end up getting really cheap rates, and overall you could say, well, that's how the market works. It's a good thing. There's more choice. There's more choice for the young, healthy person, but not for the person who, heaven forbid, got sick. Now, on pre-existing conditions, we've got a similar situation. The challenge we have, I'd love to just pass a law that said, insurance companies, you can't exclude people based on pre-existing conditions. The problem is, what they'll say to you is, well, you know what prevents somebody from not buying insurance until they get sick and then going in and just buying it and gaming the system? So we've tried to respond to a difficult problem by saying, well, let's make sure everybody has some coverage. Without that, it's hard to do. So I just wanted to respond to, yes, we've got a philosophical objection, but let's not pretend that any form of regulation of the insurance market is somehow some onerous burden that's going to result in terrible things happening to consumers. That's a good thing.
Mr. President, if I could respond.
Please.
We again have a very difficult bridge to gap here because I know that this is something that we don't want to look at, but these are, as you say, the complexities of what this is about. But when you start to mandate that everyone in this country have insurance, and you lay on top of that now the mandates that we all would like to see in a perfect world, there are consequences to that. We just can't afford this. I mean, that's the ultimate problem here is in a perfect world, everyone would have everything they want. This government can't afford it. Businesses can't afford it. That's why we continue to say go step by step, try and address the cost, and we could ultimately get there. But we're asking that you set aside this mandated form of insurance this mandated form of health care regulation, and let's go back to things we can agree on without this trillion-dollar attempt here. That's all.
I think the cost issue is legitimate, and whether we can afford it or not, we'll be discussing that. And I think that's an entirely legitimate discussion.
Mr. President, could I have 10 seconds? Literally 10 seconds. We don't have a philosophic disagreement. If you agree that you can't be dropped, there has to be dependent coverage, if there's no annual lifetime cap, then in fact you've acknowledged that it is the government's role. The question is how far to go. So this idea we have a fundamental philosophic difference, you're either in or you're out. You say the government can't do it, none of it, or they can do some of it, we argue how much.
The cost issue is legitimate. We're going to address that.
Mr. President, if I could, it's the cost issue, but it's being driven by the fact that you've got in the bill, which I assume that your proposal supports, that the Secretary define what a health benefit package should be.
Only in the exchange. If only as part of the pool that people who don't have health insurance would buy into. If you were working at a big company that already has a big pool, then but you know what, I want to make sure, because Erica, we're going to end up in a back and forth that cuts everybody else out. I've got on the Democratic side a couple of people that want to speak, and there are probably a couple of Republicans. We're already over time. I've burned some of it. I apologize. I'm going to go to Luis, then
to Mike Enzi.
Mike Enzi. I'll go to Tom Harkin, and then go back to Dave. So I've got 5 speakers, and I don't have a lot of time. Go ahead.
Thank you, Mr. President, and thanks to all my colleagues for being here. I am pretty succinct and pretty timely. I will not take up a lot of time, but I sure do have to say some things. The first one is the pre-existing conditions absolutely has to go. It is cruel, it is capricious, and it is done only to enhance the bottom line. This was not even anything we talked about 10 or 15 years ago, but it was mentioned that all Americans should be treated the same. Let me give you a little history on that. 8 states in this country right now have declared that domestic violence is a pre-existing condition on the grounds, I assume, that if you've been unlucky enough to get yourself beaten up once, you might go around and do it again. 48% is the higher cost for women, in many cases, to buy their own insurance. Believe you me, that is really discriminatory. In 1991, women were not included in any of the trials at the NIH because we had hormones. It wasn't until we had a critical mass of women here that said this will not do for more than half the population of the United States who pay taxes, that we made certain that diseases like osteoporosis, mainly a woman's disease, cervical cancer, only a woman's disease, uterine cancer, and others were really looked at. Up to that point, 1991, all research at the Institutes of Health was done on white males. Now, think about that for a minute, if you will. We couldn't do that because we said, kindly, would you stop doing that? It took legislation. Doing this will take legislation. I've been through this before. I was here when we had the Clinton debate. It was started, some of you will remember, by Lee Iacocca, who said we cannot export our automobiles. There is a $1,000 cost for health care in every one of them. My competitors are way ahead of me. They are eating my lunch. That was one of the main reasons, Mr. President, if you recall, that we decided we had to do something about that. In the 13, 15 years since that's happened, we have done nothing about health care. We don't export so much anymore. The automobile business is basically gone. We have done nothing to encourage entrepreneurs. The speaker spoke of this morning. We need to think more about the economic benefits of doing this. Those of us who are trying to redo some trade policies and maybe let us make something else again in the United States really want to make sure that it succeeds, and this would be a great part of that. I think it's terribly important that we do that. Also, since the Clinton health care plan, we've seen some pretty awful things. We saw hospitals abandoned to the streets, critically ill, elderly, mentally ill persons. And there was no great hue and cry out there. And now I understand there is actually a proposal, which God knows I hope never sees the light of day, that shut down Medicare and turned that into a voucher system. And where obviously we would not pay the full cost of health care, as these poor people have to go to the public market and try to find some. So what are we going to be doing then? We're going to be, once again, abandoning our elderly, abandoning our mentally ill, and our seriously ill to the streets. We're better people than that. I think it would be really a good thing for us today while we're here in this room together to really think about what's absolutely important here. Not nitpick over little pieces of this and that, but think about all the people out there every single day. The number of people with excess deaths because they have no health insurance. I even had one constituent, you will not believe this, and I know you won't, but it's true. Her sister died. This poor woman had no dentures. She wore her dead sister's teeth, which of course were uncomfortable, did not fit. Do you ever believe that in America that that's where we would be? This is the last chance as far as I'm concerned, particularly on the export business. We have fallen behind. We're no longer the biggest manufacturer in the world. We've lost our technological edge. We have an opportunity to do that, but a major part of the success of that is getting this health care bill passed. Thank you very much.
Louise, thank you. I was just informed. And by the way, this has been a terrific conversation so far. The House had to schedule a vote on an item, and my understanding is it has already started. So what I'd like to do is this. We've got 4 remaining speakers, Mike, Enzi, Dave Camp, I guess, again, and as well as Tom Harkin, 4 remaining speakers, and Jay Rockefeller. What I'd like to do is to break so that the House can take the vote. When we come back, we will start with Mike, and we will return to finish up the issue of insurance reform, and then we will move on to the questions of coverage. All right?
Mr. President, can I
So we are scheduled to be back here at 1:45.
I just want to inform the House members, Mr. President, there's only one vote. The vote is on. Obviously, they'll hold it until we get there, but we need to vote and then come right back.
All right. Thank you, everybody.
Buses outside.